Dear friends, I'll be talking about endoscopic anti-transcervical approach for Atlanta-axial dislocation. Nothing to declare. Main pathology in AAD is in facet joint, which can be addressed from anterior or posterior side as shown. This is the facet joint, so this can be approached either from posterior side or from the anterior side. Anterior approaches such as transcervical approach, transoral or transnasal approach as shown here have the advantages. Both decompression and fusion can be performed if pathology is not reduced. Endoscopic transcervical decompression and C1 C2 lateral mass fixation has been described by us for the first time. Although open C1 C2 transarticular fixation, endoscopic C1 C2 transarticular fixation, and endoscopic transoral atlantoaxial reduction and fixation were described earlier. I'll be discussing anterior transcervical approach, which is largest reported series in the world literature. It is indicated for both mobile and fixed AD, but it is especially useful for irreducible atlantoaxial dislocation. This can also be used for extradural anterior midline lesions. This is possible when mandible angle is lying at or above C2-C3 disc level on extension of the neck. This is contraindicated when mandible angle is lying below C2-C3 disc space. This is also not indicated when there is associated posterior compression such as cherry malformation. It is also not a good choice when facet joint is involved either by trauma or by any other disease. This is one such example of contraindication. The mandible angle is lying at C4, so this is a contraindication for transcervical approach. In workup, plain X-ray is done in neutral, flexion and extension. CT scan is especially useful to know the facet joint anatomy. CT angiogram should be done in all cases to know the course of vertebral artery and ICA artery to avoid its injury. MRI is useful to know the neural compression. In surgical technique, supine position with neck extension. Incision is 1 to 2 centimeter below the mandible to prevent injury to the marginal mandibular nerve. Mobilization of submandibular gland, posterior belly of digastric and its attachment to the hyoid bone and hypoglossal nerve is done. Identification of hypoglossal nerve is performed. Prevertebral fascia is cut and dissected. EZGO system was used in R series, but you can also use any other system. Further dissection is done under the endoscopic control. One should first identify the important structures: C1 antitubercle, both the facet joint, C1 C2 lateral masses, midline of C2 C3 disc space. One should also remove tough and fibrous anterior structures which are lying anterior to these structures. Realignment of C1 C2 is tried by inserting the osteotome into the facet joint under fluoroscopic guidance and proper positioning. Bilateral C1 C2 lateral mass fixation is done if alignment is achieved, but if the alignment is not achieved, then both decompression and fusion should be done. Screws should be placed at lower and medial half of C1 C2 lateral mass with 10 to 15 degree cranial and lateral angulations. This is a short video. This is the radiology, incision, mobilization of submandibular gland, mobilization of the posterior belly of digastric and its detachment. This is hypoglossal nerve, which is also sharply dissected and mobilized. The soft tissue anterior to the C1 C2 region is dissected. Gauze pieces are placed, and after that all the structures, the facet joint, the midline of C1 and midline of C2, C3 disc space is identified. In this case, complete reduction was not possible. Therefore, decompression was done. The part of the anterior arch of the C1 and odontoid process and part of the C2 was removed as shown here. Complete decompression until you find a good dural pulsations. Sometime you might have to remove the ligaments anterior to the thecal sac. This is the graft which has been put in on the right side of the facet joint, and then the screw is placed at the C2 lateral mass and then at the C1 lateral mass, and then these are similar thing is done on the opposite side, left side, graft placed, and then you place the C2 screw with plate, and this is the final bilateral plate and screw in position with well decompressed thecal sac. We have operated 107 patients so far. Intraoperative reduction could be achieved in 75% of patients, in which only fusion was done. But in 25% cases, reduction could not be achieved, so both decompression and fusion was done. Anterior arch of the atlas could be spared in majority of the patient. All patients improve except 2 patients. These were because of the poor neurological status before surgery. The average duration of surgery was 145 minutes and average loss of blood was 70 ml. Malposition of screw in the canal, redislocation and respiratory infections were observed in 1 patient, 2 patient and 7 patient respectively, and these were because of the either technical errors, poor bone density or poor respiratory reserve in these patients. 2 patients died and 2 patients did not improve, all because of poor neurological status and because of poor respiratory reserve. These are post-operative imaging which shows well-placed screws in this child and in this adult, and 3D image showing good placement of the screw and plates. The advantage of procedures are both decompression and fusion can be done, and this avoids contaminated corridor as against transnasal and transoral approach. There is longer and bicortical screw purchase. There is no harm if the screw projects beyond the posterior margin of C1 C2 lateral mass. There was less bleeding because there was no venous plexus, minimum tissue dissection as compared to posterior approach. There was also preservation of posterior tension band. The muscles were not detached from the C2 spinous process, which are crucial for cervical alignment. There was no injury to C2 ganglion. There was less risk of injury to the vertebral artery. There is better patient positioning in supine with neck extension as compared to prone position with neck flexion in the posterior approach, which can damage cord. One should be very careful in certain situations. There is a learning curve. This is not possible when mandible angle is below C2 C3 disc space, although rare, but there are chances of injury to ICA vertebral artery, and there is difficulty in placement of the screw at C2 lateral mass when there is a high riding vertebral artery. There is some risk of hypoglossal injury when you put in a screw at C1 in very small percentage. One should look for the abnormal course of vertebral artery which may get injured when these are lying anterior to the facet joint. One should also be careful when there are various degree of high riding vertebral artery. In these cases, placement of the C2 screw is difficult. So in such situation, when you cannot place screw at the lateral mass of C2, then you can place a screw at the C3 vertebral body. ICA may also be abnormally placed as shown here. It is in front of lateral mass of C2. For detail, you can refer to our article published in journals and chapter in the book. You can also watch our videos on YouTube. So to conclude, endoscopic transcervical approach is safe and effective in selected patient. There is a need for proper assessment and improvement of the respiratory reserve, the bone density before surgery, and one should also pay proper attention to all steps of surgery. I am thankful to my teachers. Thanks.